and this is Life with Jason Clemmons, DC. We're coming to you live from the Rock Health and Wellness Center studios in Lubbock, Texas, the mecca of health and wellness. And this is Tuesday, July the 16th. We're also live on 98.7 Walk by Faith Radio and 1420 AM Lubbock Christian Nation. We get streaming all across the country. I was talking to one of my ladies today, and she was talking about her husband that drives down the highway and spends a lot of time in Kansas and Oklahoma. And I said, well, that's awesome, because about 6 o'clock she could stream us right there on his radio. She said he listens to the radio a lot, and he could just stream us right there on his radio. He could go to his phone and get the Live 365 app, and he could listen to us as he's driving down the highway somewhere. If you guys are driving home from work, you can listen to us that way. If you get outside of our listening area on 98.7 Walk by Faith Radio or 1420 AM, then you can use that app, and now you got us. You got us anywhere that you got internet. So that's good. You can also stream us at 987radio.com if you're trying to get us on all those platforms. And also you can get us at Facebook at the Rock Health and Wellness Centers. You can get us at Twitter, X, at Jason Clemmons DC, and you can get us on YouTube at Health from the Rock. So if you want us, you can get us. Hope you guys have had a great day. If you notice, I've got a little congestion. I'm irritated. I think I did it to myself. I think I had too much fruit this summer. I don't know what I'm just a little bit too much sugar from that fruit. I haven't changed my diet 27 and a half months since I've had a sniffle, and I've got a sniffle today. Had it on the weekend. Been fighting it off. It's not done anything. There's no fever. There's nothing else with it. Just kind of a little head cold, kind of a congestion type of deal going on. We'll see what's going on. So I got my water with me. I got my little Ricola lozenges, and so we'll be getting through the show. My voice is a little bit different today than it has been, but my heart's good. My brain's good, I think. So we got a lot to go over today. And it's so awesome what happened today, because I was getting ready for the show this afternoon and putting together some slides for you guys, because I wanted to pick up exactly where we left off last night, because I think it's one of those subjects that the more you can talk about it, and the more that you guys as listeners can finally understand it, the more you can actually have some power over the way that your body functions, and you'll know what to do. And so yesterday, after we talked the first half of the show about brain and about that shooter on the roof and that 20-year-old kid that decided that he should shoot at President Trump, and that's a bad choice for him. And we talked about how maybe what was going on with his brain. So if you want to listen to that, you can go back to last night's show. I'm not a political guy really, but so it wasn't a show about President Trump or the politics of anything like that. It was kind of cool though to see that. I didn't get to watch the whole video, but it was a little bit cool to see President Trump call Robert Kennedy Jr. and talk to him about the vaccination situation. I thought that was kind of cool. We've been talking about it in chiropractic way before I got in chiropractic. It's been a subject for a long time. It was something that was a big deal for me when I had my daughter, because I didn't really understand it. But the more I've studied it over the last 20 years, I'm just so glad. It's not anything new to us. I've torn that thing apart and ripped it upside down and backwards. And the whole idea on the vaccines and all that sort of thing was, I don't know if you guys know what I'm talking about, but after the assassination attempt, President Trump made a phone call to Robert Kennedy Jr. and talked to him about, joining his cabinet if he gets reelected. And Robert Kennedy he had been videotaping himself, and he didn't get the videotape turned off, and he felt really bad. And one of his staff members, they posted the whole thing. So Robert Kennedy was pretty upset that it got posted. He apologized to President Trump about that, and because he would have never done that. It broke his trust like that. He's got more integrity than that, but it did kind of get out. So I didn't listen to it, but I just read some of the comments about it, and I thought that was pretty cool. So if politics has to do with your health, I'm all in about it. And those people that will help us with your health, those are the people that are going to get my vote. Locally, statewide, nationwide, whatever, it's nationwide. Those are the kind of people that if they're going to help us with our health and keep a strong country, that's what I'm looking for. So I didn't mean to get off on that tonight, but at the end of the show last night, we started talking about the biomechanics of the spine and what's the difference between flexion and extension in the lumbar spine. And so I put a couple of pictures together for you tonight, and I wanted to go over it with you and just continue the conversation because I think it's pretty cool if you understand it. So I think you can see this. If you guys are listening to us on the radio, you can go to Walk by Faith, their Facebook page, and you can catch some of this because they usually share that. Let me see. They've reacted to it. A lot of times they'll share it. So you can catch us there, or you can go to the Rock Health and Wellness Center's page, and you can get some of this information that we're about to talk about. So what I wanted to show you what normal, these are x-rays, and these are x-rays from the person's side, and there's a certain positioning that a person does when they take a lumbar x-ray. They cross their arms, they stand like a genie, they stand up straight, we put them up next to the bucky, we get the picture that we are trying to get without too much distortion. And what we've learned over the years is that there's normal curves to the spine. There's normal, there's the way the bones are actually made, the way that the vertebrae are actually made, and the angles of the vertebrae, and the way that the body is put together. You should see curves in your spine. You should see a curve in your neck, then you should see a curve in your mid back, then you should see a curve in your low back. And the curves in your neck and your low back match, they go in the same direction. And then that curve in your mid back, it goes in the opposite direction. And what we were talking about last night is we were talking about this mid back pain that you sometimes get. If you could just reach your hand right back behind you and put your hand in the middle of your back, and you say, you know what? Ow, that hurts right there. Like that mid back, the mid back pain, not neck pain, not low back pain, but mid back pain. And what I was trying to teach last night is that a lot of times that unless you've had a specific injury to that area, that is a secondary problem. Meaning it's not the primary problem, obviously. Good job, Jason. That's pretty good. You know, a lot as Larry the Cable Guy has said, I'm hearing a lot of this for the first time myself. So sometimes I just crack myself up, even though you may not think it's funny, but it's a secondary problem because it's not the primary problem. Okay, what does that mean? It's not the cause of the problem. It's the result of a problem that you're having in a different position, like your neck or your low back. So if your low back is not right, you can put a kink in the middle of your back. If your head's too far forward, you can put a kink in the middle of your back, and you can have that mid back pain, and you'll do all kinds of stuff to try to get rid of it because it's irritating and very aggravating. You'll get a foam roller and lay around on the floor and try to roll out your back. You'll get a tennis ball or a softball or something like that, one of those hard things, and you'll roll. You'll try to figure out what to do. You'll lay over the back of the couch, or you'll lay over the back of a chair, or, and then now you can hurt yourself by doing that. So that's not a good idea. And there's lots of different. You try to buy a strap. That's one of the things that one of the people said. How about if I buy one of those strap things, and where I can actually pull myself back? And I'm like, no, don't do that. I'm completely anti on that. Don't do that, because that's going to do is make you weaker, in my opinion. So let's talk about the 3 lumbar curves. So now we're taking this X-ray from the lumbar spine. We're taking it down here, and the picture in the middle is what we would consider to be normal. And what I want you to see is how each one of the vertebrae. So you have 5 lumbar vertebrae, and they're numbered 1 through 5. Some people have a 6th one, but 95% of us have 5 lumbar vertebrae. And you can number them 1, 2, 3, 4, 5. And then you've got a sacrum. And that sacrum is a long triangular bone. If you look at it from the front, I may have a picture of it here. Let me see. Yeah, I've got some of these other views I was looking at. They're not super clear, but the triangle comes right across the base of L5, and then it makes a triangle coming down to the bottom and back up, and that's your coccyx at the very bottom. So when we take a lumbar X-ray and we measure it, we've got some things that we can measure. Chiropractic's not just this idea of, let's just knock some high points down. It's like, hey, Papa cracked me, doc. Just come on. Like I had a new patient recently, and he was talking to my daughter. He's about, how long is it going to take? And we said, usually about an hour. And he was like, an hour? What am I going to do for an hour on my first day? And then I got the report back, and he's like, man, your dad's pretty smart. It's pretty cool, all the stuff that they did. And I'm like, yeah, because it's just not about walking in and popping you. It's about evaluating your nervous system to evaluate your health, to try to improve your health. That's what we're doing. And that's what we're doing with these films. I practiced for a short period of time in my career without films, and it was maybe one of the dumbest things I ever did. And so I'm so glad I've got these films back now. But there's three things I want you to look at. Number one, I want you to look at this angle that's down here at the sacrum. And if we draw the line across the horizon, so we have a line that just goes straight across the horizon, and then we measure what that sacral angle is. So we have a line across the horizon, and then where is that sacrum? Like if this is the table, how much tilted? In this particular case, it would be like this. So how much tilt do we have in that sacral angle? Now, if you read the textbooks are going to tell you something like 26 to 52 degrees. And that just doesn't help me at all. It's way too much of a range right there. So when you narrow it down and you kind of find what tends to be the normal, the average normal, is you'll find that about 40 degrees is what we're looking for right there. We want a 40-degree tilt. We want a 40-degree tilt in your sacrum, which is going to push your L5 lumbar vertebrae forward. It's going to put your L5 lumbar, I'm just going to say L5. It's going to put L5 forward. And then you're going to start to make the curve from L4, L3, L2 that's coming back over. And you look and you can see in this middle picture right here that each one of the bones, when we draw our green line, which is our normal, each one of the bones, the back of each one of those bones is on the green line. And if you draw a line right down from the middle of L3 and you drop a straight line down from the middle of L3, what you'll see is it ought to hit at the anterior 1/3 of the sacrum. That's considered a perfect cervical curve. If you have the proper curve, all the bones are right on the back of the normal, and L3 is landing a line from the dead center of L3, drops straight down, will hit right at the anterior 1/3 of the sacrum. Biomechanically and structurally, that's about as sound as you can get your low back. But there's all kinds of variance with that. There's all kinds of different things that go on with a person. And what I wanted to show you is kind of what happens if you have too much lumbar curve, and what happens if you don't have enough lumbar curve. And so the two pictures I showed you, the picture to the left is a sacral base angle that has been increased. And that's like really rolling your hips forward. So if you put your hands on your hips and really roll your hips forward, physical therapists call it an anterior tilt, right? That anterior tilt of that sacrum moves itself forward. Now there's several reasons that you can have an anterior tilt sacrum. One of the first ones that we always look at, that whenever I see somebody with a really strong anterior tilt sacrum, the very first thing that I look at is their feet. I'll look at their feet, and a lot of times they'll have pronation in their feet, meaning they'll have lost the curve, the arch in their foot, and now their foot is flat and they're rolled on the inside of that foot. And they're not walking properly, they're not toeing off, because there's a proper way that your foot should strike the ground when you're walking. On the outside of your heel, roll down the outside of your foot, roll across the ball of your foot, and press off. The pressing off part of your foot is what accelerates you into that next step. So you should have acceleration through that foot. Well, if your biomechanics is lost in your foot, if now your foot is dropped, or you're walking on the inside of your foot, or you're not following that, you're not hitting on the outside, rolling across and toeing off, if you're not getting acceleration from your foot joint, you will start to pull with your hip flexors. You will pull your hip through, you'll pull your leg into the next step instead of pushing your leg into the next step. And a lot of times that person's their feet are going to slap the ground and make a kind of a thud when they walk. If you got some kids like that, just want to stand behind them. That's what it flips me out when I go to the mall or any sort of shopping experience with Leslie. And I stand out there and drink my coffee and I watch people move. Man, I'm telling you, that it almost makes me wish I would have been an orthopedic surgeon, because it's like knee replacement galore, right? Because that's what your foot's going to drop, and then your knee's going to your foot's going to turn in, and when your foot turns in, your knee's going to turn in. You're going to put all that pressure on that medial meniscus, and then pretty soon you're going to say, "Doc, it's bone on bone." Yep, that's what you're going to say, because it's not functioning properly. I love biomechanics, by the way. I don't talk about it a whole lot, but I love it. We could talk about it for a long time. So let's get back to the lumbar spine. The lumbar spine is, so now we've got an increased sacral angle. So when I measure that, instead of having 40 degrees from what I'm looking for, now what I've got is 52.5 degrees. So what do we have now? We've got an increased tilt in our sacrum. We're really leaning forward with our sacrum. And what does that do to L5? Well, it really pushes L5 out in front. And now, if you're going to get your balance, because you're not going to walk around with your head way forward, right? You're gonna have to pick your head up and get your head at least somewhere over your shoulders, and get your shoulders somewhere over your pelvis so that you can walk around. So when you have an increased sacral angle and you have an anterior L5, you're also going to have an anterior L3. So if we were to drop a line down here we make this anterior weight bearing line with L3, and we drop that line straight down, a lot of times what we see is that line hits in front of the sacrum. It doesn't hit at the anterior 1/3 of the sacrum. It hits out there in front of the sacrum. And what we've got to do is we really have to bring that lumbar spine backward in order to get some sort of balance over our feet. And what we do right there is we increase our lumbar curve. So this particular one we're looking at, we've got an increased sacral angle. We got an anterior tilt of the sacrum. It's 52.5 degrees when I measured it. And we've got anterior weight bearing of L3. And we've got a lumbar angle of 65.2. Well, a 65.2 lumbar angle is, this is a 63.1 overall gain from normal. The 63.1%. This is a 63% overall gain from normal. And that's what that does most of the time I see with this. I'm not saying 100% of the time, but most of the time what I see with this is what's called facet jamming. These joints on the back of the vertebrae, the joints on the back of the vertebrae they make a joint with the one above it and the one below it. They'll make a joint. It's called a facet joint. And that facet, because we've increased the angle of the sacrum And now we've had to pull that whole thing to come back. Now what we've got is we've got jamming of the facets. And the jamming of the facets is going to give you a bilateral backache. It's going to give you a backache on both sides, right about where your belt line is. And it's going to feel really good to lean forward and stretch. It's going to feel really good to lean forward and stretch. That's what facet jamming is. So it's very important to understand if you have an increased lumbar curve, if you have an increased sacral angle and an increased lumbar curve, that you want to be careful doing anything that increases your lumbar curve. You're already maxed out. You don't need a lot of lumbar support. One of the things, if you sit down in a chair and you put your hips as far back in the chair as you possibly can, just push your hips in any chair, not a big sofa chair, but just put your hips as far back as possible. Not as far back as you can, because your legs might be really short. And if your legs are really short and you sit down, your hips aren't back in the chair. If you're really short, you got to push your hips back in the chair, and your knees are going to be you're not going to be able to bend your knees, because your knees are going to be in the chair if you're really short. But sitting all the way back in the chair and then sitting up in the chair, that gives you the most lumbar support that you're going to get out of a chair. A person that's got this problem, that has an increased lumbar curve, doesn't need to sit with their hips all the way back in the chair. It's going to jam the facets even more. Another thing they don't need to do is what I wish they could, because listen to me, sleeping on your stomach is the best place you can sleep. It's the best position to sleep in. Sleeping on your stomach is the best position to sleep in. Controversial? Okay, yes, fight me. Go ahead. It's the best thing for your brain, okay? But it's really hard on your lumbar spine if you have that much curve. It really is, because now you're going to put your head on a pillow, or you're going to put your hands underneath you, or if you're a woman and you've got extra tissue in the front, then you're going to push your shoulders back, and that's going to extend more, and you're going to jam the facets, and you're going to feel it in your low back. So that's another thing you don't need to do. Another thing you don't need to do is when you're in the gym exercising, you don't need to do exercises that really go into extension. You don't want, I'm all about flexion to normal. Like flexion to normal. I'm cool with that. You don't need to go into extension. If you're doing GHD extensions in the gym, or Supermans, or any of those sort of things, and you've got this increase lumbar curve, all you're doing is going to jam your facets. So I think it should be down, back to normal, down, back to normal. That's my opinion on that deal. Okay, let's talk about the other side. And let's talk about what happens if it's too flat. Well, let's look at the picture that's on the other side right here. This picture represents, and basically if you just look at the red and the green line, it explains the whole thing. You can look at the normal, you can look at the one in the front where we've got the anterior tilt, and you can see where the red line is out here in front of the green line. The back of each one of those bones is not on the green line, it's out in front of it. Well, now look at this picture, to where what we've got here is we've got a decreased sacral base angle. It went from 20, that's what I'm saying. I'm showing you what's considered to be normal in the textbook. A 26-degree curve, that's a 25.3, so we're pretty close to 26. The normal in the textbook tells me, as long as it's 25 to 52 degrees, it's within normal range. I get it all the time. I get X-ray reports from medical radiologists all the time that say, no, nothing found. Normal, everything's within normal limits, all the curves, all that sort of thing. And it's like, we just look at it differently. Medical radiologists are looking for an X-ray for tumors, dislocations, and fractures. That's what they're looking for. I'm looking for nervous system function and wellness. That's what I'm looking for. I'm telling you, those two things are not well. They're not well. I don't care if you got symptoms or you don't have symptoms. Those are not well. They're working against you instead of working for you. So the sacral base angle here is 25.3. What we should see is normal. So now what happens? You've got a posterior tilt of your sacrum and your butt's flat. Like, no, never mind. I can't say that. Your hips are turned under. Like you're tucking your glutes up underneath you, and your butt is really flat. Well, when that happens, that decreases the sacral base angle right there. And what are you going to get with L3? You're going to get, first of all, you're going to get L5, which is moved backward. And when L5 moves backward, now L3 is going to move backward usually a little bit. And so now if you drop a line down from the middle of L3, it will hit somewhere behind where it's supposed to hit. I got to take a break. We'll be right back right after these messages. And so stick with us. Sorry, that break snuck up on me right there. So we'll talk for a second while we're going to. We'll let the radio pay some bills there for a second. And people ask me, Doc, what kind of exercises should I do for my lumbar spine? I can't answer that question unless I understand what your lumbar spine is doing. I can't, and no one can answer that question honestly. No one can answer that question. What's the word? What's the word I'm thinking about? Professionally, you can't do that. Like, should I say everyone should do core strength? Yes, okay. Everyone should do core strength. That's fair enough. But how do you do core strength if you've got an increased lumbar curve like that versus if you've got a very flat lumbar curve? Because one of the things I want to cover when we get back is the difference in what I see usually with a person that's got a very flat lumbar curve. And there's a couple things. I'll cover it on this just as an extra. But a lot of times when you look, let's see if I can do this real quick. I think we've covered this in the past, but okay, here's the nose, there's the face. There's the cervical curve, there's the thoracic curve, there's the lumbar curve, and there's the sacrum at the very bottom. So you've got four basic curves in your spine. And you're looking, when you look at a person from the side, and when you look at them from the front, it should line up straight from top to bottom with the hips, shoulders, and ears level. That's what we look for right there. But if you take this spine over here and you flatten it out, you make the cervical kind flat, and you make the thoracic spine flat, and you make the lumbar spine flat, a lot of times what we see is the body starts putting in the curves like that. It'll put them in on the side. So let me get us back on the radio. Okay, everybody, we're back. This is Life with Jason Clemmons, DC. We're breaking down lumbar spine biomechanics and kind of what goes on there, just so you kind of know what's going on. Because I had this week in the office already. And so I just wanted to make sure that you understood it, because we're talking about what happens now if you have a posterior tilt. So now you bring your hips backward, and you've got a posterior tilt. You've got L5 that's back. You've got L3 that's usually drop that line down. It's usually posterior weight bearing, and you can see right here we've got a decreased angle of that whole thing. We decrease our lumbar curve. Instead of a 40-degree lumbar curve, now we've got a 21.6-degree lumbar curve. And what I usually see with that is I see bulging disc. I don't see facets usually. So it's what we don't see so much. We don't see the facet jamming near as much as we see the disc bulge when it's flat, and that gets into vectors. And whenever you're dealing with vectors, you're dealing with the weight. It's just like a bridge. It's the weight of distribution on the spine and how those discs are getting compressed over time. And the article, if I could get to it tonight, I'll talk about this article on disc nutrition. But if I don't, we'll cover it tomorrow night. But so a lot of times you're more susceptible, maybe I should say, you're more susceptible to a bulging disc problem with a flat curve in your spine, whether it's your cervical spine or your lumbar spine. You're more susceptible to a disc bulge than you are a facet jamming. Now, I had an interesting conversation today with one of my guys, and he said he's been told by other providers that his discs are just, his spine is all worn out, his discs are worn out, and there's nothing he can do for a bulging disc. And I told him, I said, listen, when I send a person for an MRI, the only thing that I really care about is I just want to know from the surgeon, yes or no, do you think this person needs to have surgery? That's it. That's the only two things. Now, it doesn't mean that I agree with them. It just means that that's what I'm looking for. I'm looking for their professional opinion. Do you think this is a surgical candidate? If the answer is no, then coming back to us is the place to come. I mean, like, I want you back in the office. Like, we can work on you. We could go to work on you in all the ways that you need to get worked on, physically, chemically, and mentally, emotionally, all of them together. Not because it's not just about one of them. It's not just physical. It's just not physical rehab all the time. I've broken that down for you 1,000 times on this show. Sympathetic stress releases cortisol. Cortisol inhibits the cerebellum. The cerebellum has got intrinsic muscle tone around the spine. Get yourself stressed out, you'll increase your chances of bulging your disc. So if you're going to reverse that and you're going to help a person that has a bulging disc, you got to address their mental emotional stress. You got to address their right hemisphere overactivation, firing down to the adrenal gland, releasing the cortisol, and because otherwise they're going to continue to have that same problem. And if you treat it as a physical problem and you don't address the chemical and the mental emotional aspect of it, you'll have very little success, and the patient will get frustrated. And the patient will say, you know what, I've tried that and it didn't work. It's like, yeah, I tried to use a crescent wrench as a hammer too. It's not that good. It'll work every once in a while, but most of the time it sucks, really. So you got to make sure that you're using the right modality for the right problem, and you have to address the full person. And that's what I'm saying. If your surgeon doesn't think you need surgery, come on back. Let's go to work. And I haven't known of a bulging disc that is not. I hate the word fixable because I don't fix you, but let's use it in this sentence. I don't know of a bulging disc that's not fixable. You just got to give it enough time, and you got to give it the proper amount of care. But to say that you have a bulging disc today, and then 5 years later you say, "Yeah, I got that bulging disc that bothers me." That's not how your body works. Your body's a self-healing organism. Your body heals bulging disc. There was some kind of research that said when the MRI technology came out, it's like 88% of people have bulging discs that are asymptomatic. I don't know if that's true or not, but that's a study that I heard. So if you're flexing or laterally bending one way or the other, you're going to get some sort of problem there. So if you have a decreased sacral angle and you have a decreased lumbar curve, then you're probably going to have more of a problem with your disc than you are with your facets. Now, the problem with treating these is that a lot of times they're just almost 180-degree opposite from each other. If you have facet jamming, one of the things that feels really good is to lean forward and open up those facets. But if you have a bulging disc, leaning forward is going to put pressure on the front of the disc and shoot the disc out the back, and that's going to cause you to have more pain and more problems. So the things that we do for a person who has facet jamming is we try to open those facet joints. We try to ease up those psoas muscles. We try to see if we can get some sort of neurology working at the same time, and see if we can take away some of that curve. Watch them when they're sitting. Try to get that thing to not flare up so much. Be careful about activities that they're doing. And then the things that we do with the lumbar curve is kind of the opposite of that. We want you to sit all the way back in the chair. We want you to push your hips all the way back in the chair. We want you to go into extension. There's some orthopedic tests that we could do too without having x-rays that we can kind of determine, and especially a clinician that sees a lot of patients, that's been seeing patients for a long time, can figure a lot of this stuff out without needing the x-rays. I'm not saying that it's 100% necessary to get the x-rays. I'm just saying that's super helpful for me to evaluate the curves to make sure that we're going in the right direction. But sit back in the chair, increase your support. There are some things you can do. Lay on your stomach, raise your head up off the table, go into extension, keep yourself out of flexion. Flexion means that you're taking the vertebrae and going forward. Flexion is bending your lumbar spine forward. And you don't want to do that when you have disc problems. Okay? So let me take a minute because it really did work out today. And then I want to come back and I'm going to show you some other pictures. But let me take a minute and show you this article that just happened to pop up. I was like, how cool is this right here? Like, this article just happened to pop up at the on the same day that I was going to talk about disc and disc health and all that sort of thing. And what it is here, I'll show you the whole thing. Intervertebral disc nutrition, a review of factors influencing concentration of nutrients and metabolites. This is Orthopedic Clinics of North America, 42, 2011, pages 465 through 477. And you can see the names there. This site's 112 references. And so now we're switching gears just a little bit, and now we're talking about how do I keep that disc healthy? What are some of the nutrients? What do I need to do to keep the disc healthy? And how does that actually work? Like, how does keeping a disc healthy work? So these guys broke down the, I'm gonna go back over here so I can see it this way, but let me try something. Yeah, there we go. Okay, so the normal human disc is virtually avascular, according to these guys, which means it doesn't have blood supply. It's got nerve supply. So I don't know. I don't know for sure. I've heard conflicting reports on that. I don't know for sure which one I actually believe. I've always heard that the outer 1/3 is innervated. And I don't know where those nerves are getting their nutrients because they've got to get nutrients. And so is the outer 1/3 of the disc also vascular, or is it not? I'm not 100% sure that I know the answer to that question. But nutrients, principally glucose and oxygen, necessary for survival and activity of disc cells, are transported from blood vessels at their margins to the cells deep within the disc matrix, mainly by diffusion. Products of metabolism, principally lactic acid, are removed by the reverse route. Now, what I was told when I was going through school is that there is a term called imbibition. And imbibition is the movement of the spine. And what they're saying right there is that there's not a lot of blood supply that's getting to that disc. And I think that's fair enough. I think that's probably a fair enough statement. There's not a lot of blood supply getting to the disc. Okay. How do we get the nutrients into the disc? Those discs have cells, and those cells need nutrients. Fuel and activation. Remember, that's what we're all about. That's what the brain's all about. We got to get the fuel. We got to get the glucose. That's what they're saying right here. We got to get the glucose and the oxygen into the cell. Otherwise, the cell's going to die. the cells are going to become dry and brittle. It's going to chip away. The cell's going to die, and then we're going to get what's called degenerative disc disease. Okay, so we got to be able to get there. Well, what I've been told my whole life in chiropractic is that because before I was in chiropractic, no one told me anything about this. That's why I'm doing this show, right? What I've been told is called imbibition. It's got to move. We got to get this. We got to keep this spine moving. And the reason we got to keep this spine moving is number one, because it charges the brain. And then number two, imbibition is the movement that actually pushes the nutrients into the disc. And once the cells of the disc use that nutrients, they will now have trash that's left over. That's what they're saying here with the lactic acid that's going on. Products of metabolism, principally lactic acid, are removed by the reverse route. Now, that imbibition, that movement, it pushes the glucose and the oxygen into the cell. The cell does its thing. The trash that's left over gets pushed back out, back to the bloodstream, and carried away. And now that process just repeats itself. So when a segment of the spine is not moving properly, what we end up with is a lack of imbibition and a lack of nutrients to the disc. And now the disc becomes dry and brittle and it doesn't function properly. Now, we'll get into the rest of it here in a second, but now you can start to see where if my omega-6 fatty acid status is too high, if my 6:3 ratio in my blood is too high, if I've got too many omega-6s, which that gives me all those pro-inflammatory cytokines and all those pro-inflammatory little molecules, now what am I doing? I'm smashing those pro-inflammatory molecules into the disc. And so what's that causing? It's causing inflammation in the disc, which increases the degradation of the disc. So now if it increases the degradation of the disc, we can start to see where it's not just the movement, but it's also the chemistry. It's the chemistry of the body that has to do with the degeneration of the disc. And I've been saying that since we started this show. I've been saying it for years because that's what I was taught. It's not just degenerative disc disease. It's not just abnormal movement. It's also abnormal chemistry. If it's moving perfectly, but you're so inflamed because you've got so many omega-6s and you're so inflamed, and how do you get inflamed? Eat sugar, drink alcohol, don't move, eat refined carbohydrates, eat a lot of things that are high in omega-6 fatty acids. Don't take your omega-3 fatty acids. Those are some of the ways. Be stressed out. Those are things that cause inflammation. So to be inflamed and moving is pumping that inflamed blood and tissue into that disc, and that inflamed blood and tissue into that disc is causing that disc to break down, and there's your chemical tie to degenerative disc disease. Yeah, it's true. Loss of adequate nutrients, it goes back to the article. Loss of adequate nutrient supply has long been associated with the development of progressive disc degeneration because it adversely affects activity and even the viability of disc cells. That's what I just said. Let me read it again. The loss of adequate nutrition, the loss of adequate nutrient supply has long been associated with the development and progression of disc degeneration because it adversely affects activity and even viability of disc cells. So loss of adequate nutrition or inadequate nutrition, I think that's just as important. The loss of imbibition, the loss of movement that's driving the nutrients to the disc cells, or inadequate nutrition that is what's causing the degeneration. Although the disc has only a small number of cells, these cells play a vital role. Such cells are responsible for making and maintaining the macromolecules of the disc matrix, and hence, ultimately, govern the disc biomechanical functioning. What does that mean? That means that the more unhealthy a disc gets, the less it moves the way it's supposed to. That's what it means. If my disc get worn out, then they start to move differently, and they decrease my ability to adapt. And that's when I can start causing problems for myself. Now, there are things that you can do to push back against that loss of ability to adapt. And one of the things you can do is to be moving, to be fit. Sorry, my throat is just about running out of time on this night. So let's keep going. Let me change out my. The balance between rate of nutrient supply and rate of demand influences the nutrient metabolite milieu of disc cells and hence their activity to survive. That doesn't mean anything to us. The human disc is virtually avascular apart from a small number of capillaries that penetrate only a few millimeters into the outermost annulus. There we go, right there. That's what I was talking about. So we are on the same page. The human disc is virtually avascular, meaning it doesn't have blood supply except for the small number of capillaries that penetrate on the outermost annulus. That's where the nerve supply is. And if you're going to have a nerve, you better have some oxygen to that nerve. There's where you get a neuropathy. So there we go. We tied it back together. The outermost part of the annulus is where the nerve supply to the disc is, and the outermost supply, that means the top, the outer circle. Like if it was a tree, the outer circle around the outside, that's the area of where it has the most nerve supply, and that's the area that it has the most blood supply. Blood vessels arising from the vertebral bodies feed most of the disc. So this is important because these bones have blood vessels in them that run through the matrix of the bone. And so the bone blood vessel is actually what's bringing the blood to the disc. Is coming through the vertebral bodies, is what we're saying right here. The supply through the vertebral bodies is critical for disc health. Lumbar vertebral bodies are supplied by arteries arising from the abdominal aorta. And I see a lot of abdominal aortas that are calcified. So that's not a good thing. These arteries branch into complex systems of smaller vessels that give rise to the capillaries responsible for supplying to the disc. These capillaries penetrate the marrow spaces of the subchondral plate of the vertebral body and terminate in loops at the interface between the vertebral body and the cartilaginous end plate. So that blood vessel is coming down and making a loop, and that loop is right where that disc is right there. But it's coming through the vertebral bone. It's coming off the abdominal aorta, and it's working its way into the bone, and it's working its way up and down from the bone in order to try to bring some supply to the disc. The blood flow through the capillary bed is regulated by acetylcholine, important because that's the vagus nerve. Now the vagus nerve is involved in this whole thing. The anterior height of the adult lower lumbar disc may be more than 20 millimeters, and the mid-disc height more than 15 millimeters. Thus, nutrients have to move long distances from the capillaries at the end plate disc interface through a dense matrix of rich cells to reach cells in the disc center. There's a long way in there. A healthy disc there may be a long way between the end plate of one bone and the end plate of the other bone that's trying to push towards the middle of that disc. So how are you going to get that in there? That's what I'm saying, the imbibition. You got to move and you got to squeeze it. You got to squeeze that glucose and that oxygen into that disc to try to keep that disc as healthy as possible. All nutrients supplied by the blood vessels arise in the vertebral body and diffuse through the cartilaginous end plate lying between the vertebral body and the disc. Okay, we know that. Calcification of the end plate severely restricts the transport of even small solutes through the cartilaginous end plate. That becomes a really a big deal. If you start to have abnormal pressure on the end plate of the vertebrae, now you can start to add calcium and build bone in that end plate. And if that end plate becomes calcified, it's going to decrease the amount of supply to the disc, and you're going to get a degenerative disc problem that's going on at the same time. Calcification of the end plate severely restricts the transport of even small solutes. As the disc degenerates and proteoglycans are lost, pore size increases. Pore size, P-O-R-E, pore size increases, allowing large molecules such as cytokines to accumulate, which are virtually excluded from normal disc. You shouldn't have that swelling, those cytokines. You shouldn't have that stuff in a normal disc. Loss of disc hydration will increase proteoglycan concentration and disc diffusion. In humans, load-induced variations may allow the disc to lose and regain more than 20% of its height during the diurnal cycle. Nutrients are supplied to the disc from capillaries, which are fed by blood flowing through the arteries of the vertebral bodies. And what we know about very small arteries, it's the same thing that goes on in our feet. Very small blood vessels don't need insulin to get glucose across the blood vessel wall, right? We don't have insulin. It's happening with passive diffusion. That's what we talked about with the capillaries in our feet, with neuropathy. You increase your blood sugar, you're going to have an increase in neuropathy. It doesn't matter if your A1C is perfect. It doesn't matter if your liver enzymes are perfect. It doesn't matter if your blood sugar is normal. You're still going to increase your neuropathy in your feet every time you increase your blood sugar because it's just going to diffuse across it. Now think about what happens here. In this particular case, what this is saying is nutrients are supplied to the disc from capillaries, which are fed by blood flowing through the artery of the vertebral bodies. Nutrients must be then passed from the capillaries through the cartilaginous end plate into the disc matrix. If you can't get nutrients through that capillary because that capillary is so swollen because that glucose went through that capillary wall and now it created that swelling, then you'll stop the blood flow through there and you'll stop the nutrients through there. And when you stop the nutrients through there, you increase the disc degeneration. It's chemistry. It's not just abnormal movement. Atherosclerosis of the lumbar artery restricts blood flow to the lumbar spine, has also been associated with disc degeneration and back pain. Why would you have back pain? Because if you don't get enough blood supply to that nerve is going to start to get bad. And if you swell that nerve up just like you swell that blood vessel up, that thing's going to be, anytime you touch it, it's going to set off just like your feet set off. You'll have that same problem in your spine. Hey, we've just about got to the end of the show. So I'm going to stop right here on our article. I'm going to keep our article where we are, and then we'll just pick up tomorrow night, just like we're doing tonight, and we'll continue with some of this, and we'll just see where it takes us. So I hope it's been helpful to you. I hope you've learned something. I hope it's helped the way that you function. If you got any questions for me, please send them to me, 806-794-0400. Otherwise, we will see you guys tomorrow night. Thanks for watching the show.